Welcome. Come with me. The doctors will see you now.
Welcome back to Fast Talks with Family Docs. I'm Dr. Phil Palmer.
And I'm Dr. Veer Vidala.
And today we're honored to welcome Dr. Sam Ratermann, a dedicated family physician and hospitalist at Integris Grove Hospital. Since 2010, he's provided full-spectrum family medicine in Northeast Oklahoma, from endoscopy through surgical obstetrics to leading hospitalist and telehealth efforts at that facility. And under his leadership, Integris Grove has earned a CMS 5-star recognition for both quality and safety. As a past president of the Oklahoma Academy of Family Physicians, Dr. Ratermann played a key role in Oklahoma's COVID-19 response, advocating for public health efforts and rural healthcare resources. And his leadership earned him the 2021 Champion of Family Medicine Award. Beyond medicine, he's passionate about child advocacy, community service. He's been a medical director for Good Shepherd Hospice and has also worked in forensic child abuse examinations. Outside of his physician skills, he leads scout troops, coaches youth soccer, and spends time with his wife and children. So with his expertise in all those fields, he brings some valuable insight to today's conversation. So let's get started.
Dr. Ratermann, thank you so much for joining us today, sir. Sorry, I didn't mean to cut you. What did you say?
Oh, I was just saying thank you. It's good to see you guys.
Yeah, thanks for being here. Dr. Ratermann, you have such a diverse background, and one thing that we talk about on this podcast is what all breadth of family medicine has in store for us and what different things that family medicine docs do. And you're both a family physician and a hospitalist. So I guess our first question to start us off today is what drew you to do hospital work? And do you think your family medicine training kind of gave you a different perspective on internal medicine or inpatient care specifically than other hospitalists per se?
I didn't actually go into medicine to become a hospitalist. I was in private practice for 5 years. One of the things that I learned, Russell Cole taught me this, is that back in the day, family medicine docs were really designed to meet the needs of their community. And that's a lot of how my career has gone, is just following what needs were there and what resources I could provide. About 5 years into practice, our hospital was trying to start a hospitalist program. They came to me and said, hey, why don't you run this? People know you, the community knows you, it'd be a little bit easier to get started up. And it just so happened it was at the right time of my life. I needed to make a little bit of change. I had a young kid at the time who thought I was his babysitter. Just wasn't around home very much, and the schedule kind of appealed to me. And so I made that transition and have really, really loved it. Family medicine, I love all the colleagues that I work with, but I think family medicine brings a lot to this field, from pediatrics to just holistic medicine, and especially in a rural area. So if you're a rural hospitalist, you are kind of the nephrologist at times, you're the gastroenterologist, sometimes you're the cardiologist, you're all of those pieces. And I think in some ways, family medicine is really uniquely evolved to be able to take care of very complex and antagonistic medical problems all at the same time. And so for a hospitalized patient, a lot of these things come together, and that's where family medicine really tends to shine. And I've really enjoyed it. Unfortunately, you can't do it all alone. And so as you mentioned, we're trying to bring more telehealth into that. But again, as a family medicine doctor, our job is to support those people and make sure that they have what they need and the right information and the right exam skill to help them to be kind of that person on the ground.
Yeah, and I don't have a finger on the pulse of internal medicine training nowadays, but I know when I was going through residency and even before that, looking at residencies, the internal medicine training was so heavily inpatient focused and very little outpatient that they're very skilled in that inpatient realm when they finish training to take on the role of a hospitalist. But I think family docs have the unique perspective of knowing what goes on in the clinic to a much greater degree, and the management issues and helping patients understand changes in their regimen and alterations in drugs. And so I think that transition from one family doc to the from a hospitalist family doc to the outpatient doc perhaps has the potential to be a much more positive transition, given your background in family medicine and not just general primary care as an internist.
Well, and I get to use that quite a bit, being able to call the family doc and understand what they can follow up on, what's going to be reasonable, but also just the patient doesn't have to have 10 specialists. I was discharging somebody the other day and she said, "Hey, I'm really, really anxious about this, spot. I need you to take a look at this skin spot." Okay, well, let's take a look at that. That's completely in my purview, something I've done 100 times.
Yeah.
Let's look at it, make a diagnosis, reassure her that this isn't dangerous, and you can follow up with your primary care doc when you get out of here.
Yeah.
Right.
And it's in our training too. We do internal inpatient care, but we also do like pediatric inpatient rotation. So like Dr. Ratermann was saying, when it comes into rural area, we're not we are equipped to take care of those issues as well and kind of get a more diverse perspective. I'm really interested in a telehealth hospitalist, or is it like the telehealth docs take over at nighttime while you guys are doing days, or how's that working?
That can really look a lot of different ways. So we started off with telenocturnist, so a telehospitalist that does the nighttime work, answers the phone calls, helps with admissions, critical things like that. But I think really since COVID, we've seen an explosion of what you can do with telemedicine in a rural area. We've been able to bring on teleneurology to take a look at patients, look at MRIs, make specific stroke recommendations. We've brought on telenephrology, been a really big help for those renal issues that we can't take care of ourselves or just need a little bit of extra help. Most recently, we brought in telecardiology. I've got
Amazing.
an amazing cardiologist, but he's only here 4 days out of the week. And so helping us keep some of those more complex patients in the hospital and providing the patient that reassurance that, yes, you're coming into a small rural hospital, but you still have access to a cardiologist who's going to see you and talk to you and help manage that. Right now, I'm trying to get telepulmonology. I run my own vents. I work in the ICU. We manage all that, but we also get a lot of very ill patients who have pulmonologists who are not at our hospital. We don't have any pulmonology. And so you get those patients and they say, "Man, I really wish I had a pulmonologist to look over things to make sure that my pulmonologist is going to be happy with his care." Not a problem. Let's bring those people in. During COVID, when everybody was on ARDSNet protocols and, deep sedation and paralytics and stuff that I think family medicine, at least for me, I didn't get as much experience of that in residency as I wanted to. Having those people step in and provide guidance and expertise, I mean, I just can't say enough about it. It really helped us out.
Yeah, what a fantastic resource.
That's amazing.
So, Sam, are you still involved with hospice care and end of life care? And whether you are or not, I guess, share your experiences with that and what you found in the past and still may find rewarding with that aspect of family medical care.
I love hospice care. I've been an associate medical director with a hospice company for, I think, about 13 years now. Um, there's a lot of that needs to be done in the hospital, especially when you work in a rural town in a retirement community. You get to know your patients. Sometimes you see them multiple times over a several month period and you see them declining. They get to know you, they get to trust you. And I've had personal experiences with family members through hospice, my professional experience with hospice. And those are times that you really, sit down at the edge of the bed and say, "Hey, let's talk. Where do you see yourself in 6 months? And let's set some realistic goals and what direction we want to go." And I can tell you from my experiences what this looks like, what hospice can and can't do. I think just in the last 4 or 5 days, I've had three end of life hospice conversations alone. So it's something I use every day.
Yeah, and I think sometimes in a at least in a bigger metro area where I practice, that some of the hospitalists are a little hesitant to take that role on, that, oh, I better leave this for their primary doctor. But then the primary doctor doesn't know everything that happened in the hospital and may not be for sure if that's the way to go. And I think, yeah, that as family docs, we have a great opportunity with our patients to let them know hospice care doesn't mean we're giving up on you and we're going to quit treating you. It's rather, as you said, what are your goals for the next 6 months, and what are your goals for your health care, and understanding what's going on. And again, that's kind of key and core to our profession, is empowering patients and helping them take charge of their own health care.
Yeah.
And back to your comments earlier, a lot of it is, this is my opinion. I'm going to call your primary doc. I'm gonna call Dr. Palmer, and I'm gonna tell him what I've seen in the hospital and kind of my thoughts. And if Dr. Palmer agrees, then you can finish that conversation with him. You don't have to leave or sign up for hospice now, but sometimes it's just planting that seed if it's right for the patient. But yeah, we use it. Unfortunately, have to deal with a lot of that.
Yeah.
I think it takes a lot of patience and understanding, because even in primary care, when you know these patients, it's sometimes really hard to have that conversation. And so,
well, as docs, we went in to cure.
Yeah.
And so then when you're faced with that end stage illness or the terminal condition and there is no cure, we feel suddenly very powerless.
Yeah.
And that's one of the great, in my opinion, one of the great aspects of hospice care. It does return a degree of power to the patient and their family as they transition into that stage of their illness.
Yeah, truly amazing. When I was in residency, we did like a hospice rotation, and you'd find that the nursing staff and the docs that work there, so they took it as such a privilege, and it was very moving to see, to help these patients as they transition. But Dr. Ratermann, again, kudos to you, sir, for all you do. But our next question is also, it relates to a person who must have a lot of emotional bandwidth to deal with. So you were involved in forensic child abuse exams, and I am just very curious. Like, that sounds like very difficult work. How did you get there? Did you have special training? How did you get involved, and what was that experience like?
Very, very challenging.
Yeah.
As just a quick answer, again, when you move into a rural community, you kind of fill those holes and those needs that are there. Great quote by Mr. Rogers, find the helpers. Well, we can be that helper. And so I remember I was in the community and we had this group that needed an additional doctor to help provide these exams, and they approached me and I said, well, of course I did a lot of pediatrics and was exposed to child abuse exams and things in residency. But I said, well, let me see what I can do to help. And so I just did a ton of additional training, online training, in-person training, book work, everything that I could get my hands on. Realized, okay, there's a subset of this that I really can help with, and there's a subset I can't, but let me join the team. And it was amazingly rewarding work for the most part, for really acute traumas and these kids who needed help, to be able to calm them, try to provide a avenue where they can tell their story, have an exam if needed, where they don't feel re-traumatized, and then be able to go back and advocate for this child to a team of police officers and psychologists and lawyers and district attorneys, and to help bring that story together. And then all the way sometime into the courtroom, providing testimony based on medical science of what's going on. I really do consider a privilege to have experience with a lot of people who've been, adult survivors of sexual abuse, but I've also seen the other side of people who were wrongfully accused of really heinous crimes. And so I really went into every situation saying, okay, I want to look for every piece of information that may help us prove or disprove what's going on. And in the middle, I've got this patient that needs care no matter what happened. We need to provide that care. But in doing that, you really do. You're a part of a team. This isn't a you thing. This isn't a me thing. This is, I'm going to bring my side of expertise into this and watch other people bring their expertise, and we're going to work these cases as a team.
Yeah, and obviously very emotionally charged, traumatic situation, and so valuable to have someone that can go in with a level head and kind of objectively process things to help put those pieces together and help everybody that's dealing with that situation.
Yeah, challenging. I don't do it anymore. It was one of those things I just kind of had to stop after a while, but then bring other people into the fold and make sure that they had the training that they needed and kind of transition that off. Something I'd be happy to do again at some point. But yeah, it's pretty hard to stay in that field. I did it for 10 years, and I kind of knew when it was time to get out.
Yeah. Well, Sam, you had mentioned earlier about COVID and working in the hospital during COVID, and a lot of uncertainty then for physicians, no real clear guidance on things, and shooting from the hip and taking best practices as we could get them, and obviously a lot of uncertainty and fears for patients as well. You had the opportunity to serve as the president of the Oklahoma Academy of Family Physicians during that year also. What was that experience like leading our academy during a global pandemic, and what were some challenges you faced in that leadership role, and what lessons did you bring away from that experience?
Yeah, I think I could probably write a book about that. On one side, you're in the hospital, and I mean, you said it, you don't know exactly what you're doing. You're doing the best.
Right.
You have angry, scared patients and staff, and in realms of critical care that are pretty significant. And then you're running from that patient to go get on a state call with, either legislatures or other groups, and then running back to take care of a patient. It was immensely challenging. But again, it's something we had a great team. Carrie Weber, just absolutely fantastic, running the OAFP, saying, "Hey, this is where we need you. This is what we need to do. Here's a quick debrief on information. Let's go at this together." Um, it was a big challenge, something I hope we never have to do again. Every time I hear about new outbreaks of illness, I swear I get hives. But you learn, you get firebranded, I think. And I think I really had to learn kind of the serenity prayer. There was some things that I could fix and help. There were things that I couldn't, and I really had to figure out the difference. Um, the other part of that I found really even more challenging was the politics. At least the medicine, we know what we know what we don't know. The politics was just absolutely amazing going through that and trying to navigate that field to help get messages out and not get attacked myself. I mean, there were providers in my community who were threatened because they were providing COVID care. There was people who refused to go to city hall meetings with me. They didn't want to become a target. I mean, it was in rural America, just as I'm sure it was in Oklahoma City, a very, very charged environment.
Yes.
And all of a sudden, you see your name up everywhere, and you're like, "Oh God, I just need to run into Walmart and get
Yeah.
it if I can."
Yeah. Well, we're going to take a break here, Sam. Viewers and listeners, thanks for your time, and we look forward to seeing you again on our next episode of Fast Talks with Family Docs.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast, and you will automatically be notified when it's time for your next appointment.